So again, summary, we want to recognize shock, and don't forget to recognize the compensated shock. We're going to do a point-of-care ultrasound that's guided by our history and physical. We're going to characterize their physiology, and we're going to attempt to identify the etiology, which we're going to be able to do either directly or with a deductive differential diagnosis in many patients. So identify the etiology. This is how we're going to do the ultrasound. We're going to do the heart, the IVC, and then we're going to do the chest, and we're going to do the abdomen. We'll alter the order based on their symptoms. And we're going to answer these questions. Is it obstructive or is it cardiogenic? If it's not one of those, they need some kind of fluids, and then more evaluation with ultrasound and maybe other evaluation downstream. Then we're going to look, is there a source of hemorrhage that we want to identify quickly and start blood, or is there an obvious identifiable source of infection? Now, we're going to do a quick review of some of the relevant. This is not a completely comprehensive or exhaustive review of the literature in point-of-care ultrasound and shock, but some of the key studies that are out there. The overall themes are that ultrasound makes us more accurate, we miss fewer things, our differential is shorter, we make diagnoses more quickly. Some literature has even suggested fewer days on the vent, fewer days in the ICU, shorter ED length of stay, and even improved mortality in some small studies. These are just a few references. There are many more, and these were prospective, I'd like to point out. In this study, this was the shock ED investigators. This was a convenience study. They exclude a lot of patients. Their definition of undifferentiated was a little questionable. There was a study of point-of-care ultrasound use in critically ill atraumatic patients. This was more of a retrospective database study. This is a little bit older study from 2004, but I really like this study because what they did was they took patients and either tried to make a differential diagnosis before or after ultrasound. And in this case, they did a pretty systematic ultrasound of heart, lungs, IVC, aorta, and the abdomen. The ultrasound took them about 6 minutes. On average, the differential was cut in half, and the diagnostic accuracy was nearly doubled. Now, the reason they did not withhold ultrasound in anyone is because this is back in 2004. The authors felt that it was unethical to withhold point-of-care ultrasound in critically ill patients because they had seen and they knew the difference this made in diagnostic accuracy. Let's talk a little bit about performing point-of-care ultrasound in patients with shock. Back in 2010, Dr. Pereira and his co-authors authored a review article about what they dubbed at that time to be the RUSH exam, or rapid ultrasound in shock, and evaluation of the critically ill. So I like to include those patients when I think about this. And they used this mnemonic that they called HIMAP, the heart, IVC, Morson's pouch, which just really meant doing the abdomen, the aorta, and pulmonary, but they also include the legs sometimes. This is, again, if you're thinking about massive PE and looking for signs of DVT in the legs. So you'll often hear folks talk about the RUSH exam. I don't necessarily term it that way, but it's the same kind of concept. And what we're doing, again, we're identifying shock, we're doing a history and physical guided point-of-care ultrasound, characterizing the physiology, identifying the etiology. We're going to look at the heart and the IVC. If they have respiratory symptoms, the next thing we're going to do is look at the lungs. Then we're going to look at the abdomen and pelvis, and that's going to include the aorta, kidneys, gallbladder if it's there, bladder, anything obvious in the bowel. If they don't have any respiratory symptoms, we may go from heart, IVC, and then next to the abdomen and pelvis, because that might be higher yield. We're going to look at the same things, but then we're going to come back to the lungs and look for any other etiologies or findings that may guide us. So we're always going to look at heart, IVC, we're going to look at the chest, and we're going to look at the abdomen. And depending on the rest of the physical exam, we may be looking in the skin and soft tissue. We may be even looking in the legs for signs of a DVT if we think massive PE is the etiology of their shock. With all that said, let's go back to the cases we presented initially and review the findings and how ultrasound helped us. Again, we're going to use this simple approach. Physiologically, is it obstructive or cardiogenic? From an etiology perspective, if it's not one of those things, is there a source of hemorrhage, or is there an identifiable source of infection? So our first case, this was the 76-year-old female who had syncope and was hypotensive, had some left abdominal pain and ulcer pain. It was very easy to think that this patient was having a GI bleed. But ultrasound led us down the correct path where we saw blood in the abdomen. We saw signs of hypovolemic or hemorrhagic shock because we saw a pretty normal or maybe a little bit vigorous looking left ventricle, a flat collapsing IVC, but the key was this fluid within the abdomen that led us to the diagnosis of a spontaneous spleen rupture. It's also thought maybe when she passed out, she fell and injured her spleen, but it looks more likely that this was a spontaneous spleen rupture. So identifying this diagnosis quickly with point-of-care ultrasound and more directly was able to get us to the proper treatment, get the patient to the operating room, which we could have gone down the wrong path, treating her for GI bleed and missed this diagnosis for hours or maybe even days, where she could have had a very bad outcome or possibly even died without identifying these findings properly. So we looked at her aorta, looked normal. Here's the spine. Here's the aorta sitting on top, not dilated. Here is fluid on the right side, filling up the abdomen. And here is the spleen that has irregular borders and some heterogeneous texture and color. This is all clotted blood around this spleen that's injured, in this case of spontaneous spleen rupture. In our next case, if you recall, we talked about this 56-year-old with shortness of breath, a little bit hypotensive, but kind of looks like CHF, which the patient has a history of CHF. They have crackly lungs, they have swollen legs, but when we look, the heart doesn't look that bad. The IVC looks kind of flat and collapsible. And when we look at the lungs, what we see here, this is a pretty significant infiltrate right under that rib, and we see some B lines around it, which led us to the diagnosis of pneumonia with septic shock, which is going to get much worse if we give this patient nitroglycerin and diuretics. Another example of where ultrasound dramatically changed this patient's care very early on in their course and led to improved diagnostic accuracy, decreased diagnostic error. And just for the sake of practice, a few more examples and findings where we see these subpleural lesions, sonographic B lines, big subpleural lesion, sonographic B lines here, pleural irregularities associated with this lesion. These are all consistent with infectious or inflammatory findings in the chest. So that initial concern for CHF immediately changed after an ultrasound to treating for pneumonia and septic shock. Now, I don't know about you, but I treat septic shock very differently than I treat CHF. Third case, and these are the kind of cases that we hear about a lot, luckily with point-of-care ultrasound not as often nowadays, but this is a patient who was transferred to the ICU with quote-unquote pneumonia and septic shock, with refractory hypotension. We see this is a big pneumonia maybe on this x-ray, but within minutes, ultrasound helps us identify cardiac tamponade, large pericardial effusion, pinches up between the descending thoracic aorta and the left ventricle. The right ventricle collapses during diastole, but also take note of the compressed left ventricle as well. These are pretty definite findings of cardiac tamponade, and if this is your patient, you need to be draining this as quickly as possible. Just some further images to illustrate the findings. So we see circumferential, large amount of pericardial effusion, and notice that it pinches between the descending aorta and the left ventricle and left atrium. We see the collapse of the right ventricle during diastole, and we also see that the heart is just small and overall compressed. We see that here as well, and we can actually see the border of the pericardium, and then there's an associated pleural effusion in this patient as well. But see how small and compressed that heart is? That's a sign of tamponade if I've ever seen one. Shouldn't wait around to drain this fluid. So obviously this is obstructive shock. The tamponade was drained. The shock resolved very quickly, and the patient was weaned off of pressors in very short order. In our next case, this is a patient who presented with acute shortness of breath and hypotension, clear lungs, tachycardia. In this peristernal long axis, which we see left ventricle, we see the mitral valve and the aortic root. This is a good judge that we're seeing as much as we're going to see of the left ventricle, and we can see this right ventricle just looks dilated and it's compressing the left. On the apical 4-chamber view, we see a large dilated right ventricle with compression of the left. We see McConnell's sign here. We look a little bit further, and in the apical 4-chamber view, we again see a dilated right ventricle and compressed left ventricle. We see paradoxical septal motion, so the septum pushing towards the left. And in cases like this, where maybe the patient's too unstable to go and make a definitive diagnosis, we can look wherever we think there might be a clot. If there's no other source, we just look at both legs. Here we identified a left femoral DVT, which was likely the source clot causing the massive PE. So with this very compelling circumstantial evidence, a diagnosis of massive PE was made and thrombolytics were given, and the patient recovered and did very well. In this next case, we have a confused young man with hypotension and tachycardia. Not a lot of history because the patient's a little obtunded and not talking a lot. But when we take a look, what we recognize is a hyperdynamic left ventricle, and we see these thickened hypermobile masses on the mitral valve that are suggestive of endocarditis and a mechanical cardiogenic shock. Now, they probably are septic and have some component of distributive shock as well, but recognizing the findings of endocarditis drastically is going to change how you manage and care for this patient. So this is a pretty compelling case of mitral endocarditis, which is causing probably not only septic shock, but also mechanical cardiogenic shock. So just to kind of sum up and go over the findings, and we've talked about these things, kind of hit them at multiple points throughout this discussion. The things that are important to do is, one, don't forget to recognize shock. And remember, compensated shock may show up with some of these more vague symptoms or findings like syncope, fatigue, confusion. So unless you have another clear reason for those, I like to consider those to be compensated shock, and I apply ultrasound to those patients. Characterize your physiology, and if you like the mnemonic CHODE, look for an etiology. After you've ruled out obstructive and cardiogenic shock, look for signs of hemorrhage or identifiable infectious sources. Our point of care ultrasound after we identify shock is always going to be guided by our history and physical. We're going to characterize the physiology, and then we're going to hopefully be able to identify a specific etiology. The 4 questions to ask yourself is it obstructive? Is it cardiogenic? If it's not, you're going to probably start some fluids while you look further for sources of hemorrhage or an infectious etiology of their shock. If you identify an obstructive cause, then you're going to take measures to treat that. Same with cardiogenic, although don't forget to ask yourself, is this primarily cardiogenic shock? Pulmonary edema will add to that. Or is this a patient who has underlying cardiac disease or cardiogenic complications of their shock? Take a pretty systematic approach where you look at the heart and IVC, and then you're going to make your way around to the abdomen, including multiple organs, and the lungs, the order of which depends on which symptoms the patient has. So with that, I hope you have some of the things you need to go out when you see patients with shock, get the best history and physical that you can, and then let that guide your point of care ultrasound to help you identify the physiology, their etiology, make diagnoses you wouldn't have suspected, make them quicker, be more efficient with your use of resources. And I promise you, if you apply this in patients with shock, you're going to find things you didn't suspect, you're going to find them earlier, and you are going to save patients' lives. And I can't think of a more compelling reason to incorporate ultrasound into your practice.